All right, let's get right into it. Geriatric care can feel like one of the most overwhelming topics in nursing, right? Well, today we're going to break it all down. We're going to turn these dense concepts into a super clear visual guide that'll have you ready for any exam. Let's do this. So here's our game plan. First, we're going to tackle the myths, the things we think we know about aging. Then, we'll dive into the really critical skill of spotting when a disease looks, well, weird. After that, we'll untangle the 3Ds, talk about the biggest safety risks, and then wrap it all up with a quick hitter review to make sure it all sticks. We're building from the ground up, from your mindset straight to your clinical actions. Before we even think about assessments or vital signs, we have to start right here with ageism. And you might be wondering why. Because these common biases we all carry around, they aren't just incorrect, they can lead to some seriously dangerous clinical mistakes. Truly great geriatric nursing starts with seeing the individual, not just a number or a stereotype. Now take a look at this. This isn't just about being politically correct. This directly affects how you assess a patient. I mean, if you walk in assuming all older adults are confused, you're way more likely to brush off sudden confusion as just old age. But what if that confusion is actually the #1 sign of a raging infection? See what I mean? These aren't just harmless ideas. They are clinical traps waiting to happen. And this right here, this hits the nail on the head. It's totally normal for processing speed to slow down a bit with age, just like hearing can change over time. But slower is not the same as dementia, not even close. So the big takeaway here is you, the nurse, have to be the one to adjust, slow down, give them a minute. If you rush, you're going to end up with the wrong answer. Okay, everybody listen up. This next part is, and I'm not exaggerating, maybe one of the most critical concepts in all of geriatric nursing. As we get older, our bodies just don't have the same reserves to launch that big, obvious textbook response to an illness. So if you're waiting around for the normal symptoms to show up, you could be making a fatal mistake. Just look at this. It's absolutely night and day. In your younger patient, a UTI is pretty straightforward, right? Burning, fever, the usual. But in an older adult, that same UTI might show up as sudden, out-of-the-blue confusion, or a fall, or they suddenly can't control their bladder. It's like the infection hijacks their brain first. You have got to remember this. Confusion is often the fever of the elderly. And speaking of fevers, you see this number, 99.0, and you probably think, meh, no big deal. But hold on. For an 80-year-old whose normal baseline temperature might be closer to 97, this is a huge jump. This could be the only real clue you get that a serious infection is brewing. So please, never ever write off a low-grade temp. It's the exact same story with heart attacks. We're all trained to look for that classic elephant on the chest pain. But what if I told you your older patient might have 0 chest pain? Instead, the real red flags for their silent heart attack might be sudden shortness of breath, a weird feeling of anxiety, or, you guessed it, that sudden acute confusion. All right, time to untangle the 3Ds: delirium, dementia, and depression. Knowing the difference between these three isn't just a nice to know, it's an absolutely essential nursing skill. Why? Because one is a treatable medical emergency, one is a long-term condition, and one can look like both. If you mix these up, the consequences can be huge. I want you to burn these 3 words into your brain: acute, reversible, medical emergency. Acute means it happened fast, suddenly. Reversible means if you find the cause, like that UTI we talked about or low oxygen levels, and you treat it, the confusion gets better. And medical emergency means you need to act right now. Now, let's flip the coin. Dementia is pretty much the opposite. The key words here are gradual and irreversible. This doesn't happen overnight. It's a slow-motion decline that happens over months, even years. This is their normal, their chronic baseline state, not a sudden change from yesterday. Okay, quick pop quiz. A family member tells you their 72-year-old mom was totally fine yesterday, but last night she started seeing things that weren't there. What's the magic phrase here? It's last night. That's an alarm bell screaming acute onset, and that points you straight to delirium. Your job isn't to document dementia, it's to start hunting for the cause, like checking an O2 sat or getting a urine sample. And here it is, your ultimate cheat sheet. Look at the key differences. Onset, sudden for delirium, slow for dementia. Alertness, all over the place with delirium, but usually pretty normal for the other two. And the big one, reversibility. Delirium, you can fix. Dementia, you can't. And depression is absolutely treatable. Knowing this table is going to save you.
Okay, so we've got the theory down. Now let's switch gears and get super practical. Because at the end of the day, our #1 job is keeping our patients safe. So we're going to talk about the big 3 dangers: falls, medication issues, and the hidden danger of mistreatment.
You know, a fall is so much more than just a bump or a bruise. It can kick off this awful, vicious cycle. The person becomes terrified of falling again. So what do? They stop moving. They stay in their chair. But that inactivity makes their muscles weaker, which, you can see where this is going, actually makes them more likely to fall again. It's a horrible self-fulfilling prophecy that we have to step in and break.
Next up is polypharmacy, which is just a fancy word for being on a whole bunch of different medications. Here's the problem. Older adults' kidneys and livers don't clear out drugs as fast as they used to. So that means medications hang around in their system longer, which can lead to toxicity. Your 2 secret weapons here: the brown bag review, where you literally have them bring in every single pill bottle they own, and knowing the Beers criteria, which is basically the official don't use these meds list for older adults.
Okay, picture this. You're trying to talk to your patient, an older woman, but her son keeps jumping in, answering for her. He's explaining away her bruises by saying, "Oh, mom's just clumsy." What is your gut screaming at you? And more importantly, what is your priority action as the nurse?
The answer is simple, and it is absolutely non-negotiable. You have to find a way to talk to the patient alone. A caregiver who will not leave the room is one of the biggest red flags for elder mistreatment. You have to create a safe opportunity to ask those tough questions, one-on-one.
All right, we have covered a ton of ground. So let's do a final rapid-fire review to really hammer home the most important things. This is the stuff you absolutely need to take with you whether you're heading into an exam or starting your next shift.
So this chart isn't just a bunch of numbers. It's a roadmap for your brain. Look at where you need to spend most of your mental energy. 40% of your focus should be on spotting those weird atypical symptoms. Right after that comes safety, then the 3Ds. But notice what it's all built on, that 10% foundation of just being aware of our own biases.
Let's hit these one last time rapid fire. Sudden confusion? It's a medical emergency. Think infection or low oxygen. A 99-degree temp? Could be a major fever. Silent heart attack? Look for shortness of breath and confusion, not chest pain. See a concerning situation? Always interview the patient alone. And remember, slower processing is normal aging. It is not dementia.
And this is how it all comes together. This is the complete mindset. You start with yourself by checking your own biases. Then you figure out the patient's normal, their baseline. Once you know that, you'll be able to spot any deviation, any of those atypical symptoms we talked about. And as soon as you spot it, you act to keep them safe. It's a simple, powerful process.
So I'll leave you with this final thought. Now that you know how to look for these silent symptoms, what's that one little change, that thing you might have ignored before, that you will absolutely never ever dismiss as just old age again? Think about it. That shift in perspective is what makes all the difference.